For the introduction. So this session's on adenomyosis. There may be a little bit of crossover with my talk, so I'll try and skip over areas where I think there might be. So I'm going to speak to you about pain and heavy menstrual bleeding with adenomyosis. So, thank you. Adenomyosis, or I'm referring to it as AUB-A, which I'll come on to in a second. But adenomyosis is a chronic estrogen-dependent condition where the endometrial cells are located within the myometrium, and this leads to changes in the uterine structure. Now, it could be focal, and they can be hard to differentiate actually from a fibroid on diagnostics, forming an adenomyoma. But more commonly, it's diffuse, leading to the uterus becoming gradually bulkier and heavier. And of course, it's important that we recognize the association between adenomyosis and endometriosis. The problem with adenomyosis is we don't fully understand the pathogenesis. We know it's a sex steroid hormone dependent disorder, and it's characterized, like endometriosis, by increased inflammation, impaired apoptosis, and neuroangiogenesis. Estimates vary depending on which populations you look at and which diagnostic modalities and criteria you're using to define adenomyosis. But it's thought that it could be as high as 70%. Now, the common symptoms, focus of my talk is heavy menstrual bleeding and pain, but of course it can be associated with fertility issues as well, although it may be hard to sort of disassociate those from the presence of endometriosis. However, the actual relationship between the presence of adenomyosis and how that causes heavy menstrual bleeding or pain is less clear. So the reason I refer to it as AUB-A is that I'm sure you're aware of the FIGO classification, the Palm-Cohen classification, which splits the causes of abnormal bleeding into structural causes on the left and non-structural causes on the right, and that gives you the acronym Palm and Cohen. And of course, adenomyosis is the A, so it's classified within the structural side of the nomenclature. So what do we know about pathophysiology? Well, it's felt that the endometrial glands and stroma become located in a haphazard manner deep within the myometrium, and it's thought that there's some endomyometrial invagination of the endometrium, so the endometrium growing down and into the underlying myometrium. And this is thought possibly to be due to some sort of weakness in the underlying smooth muscle or an increase in intrauterine pressure, or both. But what we do know is once the endometrial glands and stroma are in the myometrium, then this leads to smooth muscle hyperplasia and hypertrophy, which is a reflection of the reactive changes of having this ectopic endometrium within the underlying myometrium. More recently, there's been interesting studies with improved imaging, sort of identifying what normal endometrium looks like, and normal myometrial vasculature, and what it looks like within adenomyosis. And it sort of correlates with what we know, that you have adenomyosis, which is sort of contiguous with the endometrium, and other areas of islands of satellites of the endometrial tissue within the underlying myometrium. Diagnosis, we rely on ultrasound or MRI, and you often see this thickened and junctional zone, and it can be, the uterus is often asymmetrical in terms of the myometrium. And again, you can identify, shown there on the right, serrated sort of junctional zone with invagination of tissue from the endometrium, or actual adenomyosis within the myometrium itself, but separated from the endometrial stripe. And this is the MRI picture where you see these white specks of adenomyosis. And also you'll often see little cystic areas and collections of fluid. Now, one of my main interests is hysteroscopy, and hysteroscopy, there isn't one homogeneous appearance of adenomyosis, but you might see little blue hemosiderin deposits, subendometrial cysts, But you might see little pits and clefts, you might see areas of hypervascularization, and these are all indicative of adenomyosis. And often your diagnosis at hysteroscopy will be facilitated by a concomitant ultrasound as well, allowing you to visualize, for example, subendometrial cysts. Now, as I was in Sitges, just by Barcelona last week, or was it the week before, I think, and Rudy Campo, who's a hysteroscopist, was giving a talk on adenomyosis, amongst other things, and they've developed this spiratome. I don't think it's widely used, but it's a special bit of kit that allows you to put that through the 5 French operating channel of a hysteroscope and take biopsies from subendometrial cysts or from areas thought to be adenomyosis. The other thing, of course, hysterectomy, often we'll find it just incidentally, or maybe not incidentally, maybe the reason why the woman had the symptoms of pain or bleeding, but often we'll find adenomyosis reported on histology, and that obviously was conventionally the gold standard way of diagnosing adenomyosis. So we don't quite understand what the genesis of pain and bleeding is with adenomyosis. We know a little bit about the pathophysiology. We know it's a highly prevalent condition. We know it's linked with adenomyosis, with endometriosis. But what we don't know is do the treatments that we use to treat heavy menstrual bleeding and pain conventionally work as well for patients with adenomyosis? So I'm going to concentrate just on these 3 medications for a second. So don't worry about this algorithm, but I was, in 2018, I was on the NICE, that's the National Institute of Care Excellence committee, when we developed this evidence-based guideline, which is available, over the net. And there was a huge amount of work done behind the scenes generating all the evidence in what's called network meta-analyses and trying to derive all the data we could. And there was I wouldn't say an obsession, but certainly when the remit of the guideline was given to us, there was a lot about adenomyosis and people wanting to know about treatments and specifically for adenomyosis. So what we did is we split the treatments essentially into 2 areas. So on the top right here is the sort of fibroids greater than 3 centimeters, and on this side you've got no pathology, so what we used to call in the past dysfunctional bleeding, or on the new classification, the palm Cohen, it would be the non-structural causes, ovulatory or endometrium, so AUBO or AUBE. So actually you can't see an organic pathology. Or, slightly arbitrarily, we took fibroids less than 3 centimeters have been relatively non-significant, or adenomyosis. So we put all those into one side of the algorithm, and then large or multiple fibroids were on the other side. And the only reason for that was we couldn't find any evidence really, or good quality evidence, specifically looking at treatments and looking at some sort of differential outcome for women, for example, with 2 centimeter fibroid. Do they do worse than a woman without a fibroid with the Mirena coil? Does a woman with adenomyosis do worse with the pill than a woman without adenomyosis? We just couldn't find any data, so we lumped them all together. And so basically what we've said, and this is based on good data from RCTs, that for women recruited to these sort of studies, the levonorgestrel intrauterine system is the most effective medical treatment for women with heavy menstrual bleeding. And within that group, there would have been patients recruited with adenomyosis or small fibroids. So therefore, that should be first-line treatment. And if that's not acceptable or contraindicated, then you can use the other usual sort of hormonal or non-hormonal treatments for heavy menstrual bleeding and pain. And so that's where we are with sort of the treatment. So nothing directly specific for adenomyosis, but lumped together with no obvious identified pathologies or very small fibroids. Now, when we do make a diagnosis of adenomyosis, then do we need to consider it? I mean, or should we just treat them as we would any other woman, whether she has adenomyosis or not? Well, in essence, yes, so we do treat them the same, but I think knowing they've got adenomyosis can be useful, particularly the association with endometriosis. And of course, treatments will depend upon a reproductive status as well as the predominant symptoms, and we have various treatment options, which may be medical, surgical, or expectant. And of course, as I say, be mindful of the association with endometriosis and with fibroids, because this might have an impact on the sort of treatments that you would choose. Medical treatment does play an important role, though, for adenomyosis, particularly when it's diffuse. And I think Marla's going to speak to us about surgical management, but you know, treating localized pathology surgically is much easier than diffuse pathology. And so medical treatment can be less invasive and potentially helpful. But as I say, there's very few clinical studies looking specifically at the subgroup of women with heavy menstrual bleeding or pain who have adenomyosis. So we've heard a little bit about Dynagest today. So this is a 19-nor testosterone derivative, so a type of progestin that does cause mild inhibition of ovarian function and has an anti-proliferative and anti-inflammatory action. And so we're using this now more in endometriosis. It has been used, so I found this trial looking at a specific treatment for adenomyosis with Dynagest. And it was a randomized study, small, only 67 patients, but it did actually show that it seemed to be effective and well tolerated. Although, interestingly, most women, whilst they found a reduction in their pain, did have problems with irregular bleeding. The Mirena device, on the other hand, or I should say the levonorgestrel releasing intrauterine system, again, can be effective, as we know, in a general population of women with heavy menstrual bleeding and with pain as well, and women with endometriosis for that matter. But it does seem to increase apoptosis and has a sort of direct effect in reducing thickness of the endometrium and myometrial junctional zone and causing sort of general atrophic change. And again, looking at trials, so this is one, again, specifically looking at adenomyosis. So they looked at the intrauterine system and compared it with hysterectomy, and interestingly found that it was equivalent, and if anything, it had greater improvement in health-related quality of life than women undergoing hysterectomy in the presence of adenomyosis. So certainly we can use progestins. I don't have a great deal of knowledge of these interventions apart from one, which I'm going to go on to, but these are experimental interventions which have an underlying rationale based on the proposed pathogenesis of adenomyosis, so targeting key metabolic pathways outside of the traditional hormonal ones to see whether there could be an impact on adenomyosis. But the one I'm just going to concentrate briefly on now is the use of the GnRH antagonists. So we heard a little bit about these oral non-peptide antagonists, elagolix, rilogolix, and linzolix. So they've become recently available to us in the UK. We don't have the top one, elagolix, but we do have rilogolix, which is marketed as something called Rieco, because it contains ADBAC combination therapy, so it's got integral HRT in it. And there's one called linzolix that's just coming on board, which will be available to us shortly as well. But they're available and licensed for the use of treating heavy menstrual bleeding associated with fibroids, nothing to do with adenomyosis. There have been trials that have been published in the Lancet and New England Journal showing the impact of these drugs' effectiveness on endometriosis and pelvic pain, but as yet they haven't been approved by the regulators because those trials came later, that the original trials were all on heavy menstrual bleeding and fibroids. So we got access to these drugs, but we're using it, as I say, for fibroid-related heavy menstrual bleeding. And just to show you these are some of the original papers in the Lancet and New England Journal. But if you just briefly look at these, you can see that you're getting, the grey is the placebo group. The two trials were identical but replicate. So for some reason the FDA, to get approval, want to have two identical trials. But you can see that the orange bar is the active drug and shows, look, a 73% improvement in the primary outcome, which was basically a reduction of 50% in blood loss from baseline, and also it was a co-primary outcome. You had to have less than 80 mils loss overall. And so very effective. And if you look here at the top grey is the placebo. So you can see the reduction in blood loss in the active drug takes place really quite quickly, certainly by week 8. Then if you look, they looked at sort of expanding the study out to a year, and you can see that they allowed the group with the placebo arm at the top then to take the active drug. And you can see a similar gradient in terms of reduction in blood loss, and this is sustained up to a year whilst women are taking the medication. So these drugs are working just like GnRH analogues, conventional analogues work. They're suppressing the pituitary gland production of gonadotrophin hormones and inducing a chemical menopause. But the one that we have, Rieco, this is Relogolix with, it's got norethistérone and estradiol in it, so it's got an HRT in it. So actually, you're in the best of both worlds, where you're not having in an estrogen deficient state, but you are suppressing bleeding. And again, in the interest of time to speed through these, take my word for it, these charts, these drugs, the Elagolix and Menstural are showing the same thing, showing the drug's very effective compared to placebo. And as regards bone mineral density, if you look at the top line in grey, that's the placebo, so no changes expect whilst on the duration of the study. But you can see in blue, when the patients were on the Relogolix on its own, then the bone density dropped. But the orange line is the line where they've got the combination therapy, so they've got the Relogolix and they've got the add-back HRT. And you can see it's reassuring that there's no significant drop in bone density. So as well as being very effective at suppressing bleeding and problems, they seem to be not causing adverse effects. And again, these, in the interest of time, these are the same charts, similar charts looking at bone mineral density, and shows the same thing for all the drugs. If you take the active drug alone, you'll drop your bone density, but if you've got add-back combination therapy within it, you won't. So they aren't specifically indicated for adenomyosis, but they are for fibroids. So what I had said originally in lectures to say, well, I think for women, if you look at the top, with fibroids, remember I showed you that algorithm, and I said on the one side was the significant fibroids, so we take this as greater than 3 centimetres. In women with bigger fibroids, multiple fibroids, this is the area where these oral GnRH antagonists are going to be useful. But what about adenomyosis? Well, we're not licensed to use it for that, but I did manage to find a couple of studies, one from Jacques Donnet, looking at Menstural as a therapy for adenomyosis. You can see on these MRI images, the bottom slide D is showing post-treatment, and you can see radiographically you're losing these echogenic foci of adenomyosis, and the uterine volume has substantially reduced. And again, they used it on a few patients and in an observational study, and again showed that it was well tolerated and it decreased the volume of the uterus and resolved pelvic pain and bleeding issues. So it seems as though this is a drug that will become available to us, and maybe we could use specifically for adenomyosis. Now, I'm not going to talk about surgical treatment because that's our next talk, but I was in Barcelona the other week, and I was just interested in, I don't do much I do a lot of hysteroscopic surgery, but not much hysteroscopic surgery for adenomyosis. But they did show 1 or 2 videos of, as I say, combining ultrasound, identifying myometrial cysts, etc., and resecting these hysteroscopically, and I thought that was quite an interesting thought, but it's not something that I do widely. As I say, the other sort of techniques we'll leave to our next speaker. Just finally, before I finish, I did look for what else was going new in adenomyosis. So uterine artery embolization we use obviously to shrink fibroids, but you can use it for adenomyosis. There is some evidence of improvement in observational studies, but you know, the quality of this evidence is limited, so it's hard to say that we should be using this technique in routine practice for adenomyosis. But of course, if it's in conjunction, coexistent with symptomatic fibroids, then I think it's perfectly reasonable. And now in the UK, we're getting pushed a lot now with something called the Sonata system, which is an ultrasound-guided radiofrequency device to try and ablate and treat intrauterine fibroids. But similarly, there are high-intensity focused ultrasound guided by MRI or other ultrasound technologies which have been used, not in the UK, I have to say, but I did find some minimal data and experience of using these technologies as radiological treatments. But I don't know at the moment, again, there's very little data to sort of say it's something we should be doing day to day, but we may see that becoming more widely discussed in the future. So to conclude, I think adenomyosis, or AUB-A, according to the Figo-Palm-Cohen classification, is common, but you know, what causes it and its clinical significance needs to be further elucidated. We identifying it more now because of improvements in scanning, particularly in ultrasound, and developing criteria as to what constitutes adenomyosis and a general consensus. Conventional medical treatments are the mainstay of treating heavy menstrual bleeding and pain. We haven't got specific evidence-based treatments for adenomyosis, although I've shown you a few examples of where there have been some small studies done. But evidence to support hormonal treatments, you know, but there are some limited evidence for some of these newer treatments. Surgery, I say I'll leave to our next speaker, but we need again more data on that, and the role of embolization, you know, remains unclear. So, as we have no evidence-based guidance specifically for adenomyosis, this is because of a lack of studies, as I say, looking particularly at women with adenomyosis. We need future research targeted at treatments, and if we are going to do studies of treatments for HMB and pelvic pain, I think now that we can scan and diagnose adenomyosis so well, we should always use that as a stratification variable and always be able to do a subgroup analysis looking at groups of women with adenomyosis to see if there's any difference in outcomes. And of course we need to understand a little more about the pathogenesis of adenomyosis so that we can you know, develop new molecules to target the condition. Okay, so that's a quick whip through pain and heavy menstrual bleeding for adenomyosis. Thank you.